Welcome to this section of MD310 Medical Care Provider. In this section, we will be discussing abdominal pain, gastrointestinal, OB/GYN, and genitourinary complaints. By the end of this session, you will be able to identify 6 causes of abdominal pain, identify and list at least 4 red flag signs or symptoms of serious disease causing abdominal pain, and list 2 early pregnancy or gynecologic emergencies. Abdominal pain is one of the greatest diagnostic challenges that you'll face. Abdomen is Greek for cavity of mystery, or cavity that conceals, and that's certainly true in medicine. Anatomically, we're talking about an area from approximately the nipple line to the proximal to mid-thighs, and pain in that area can be from any intra-abdominal cause. Also, extra-abdominal disease, such as problems with the blood vessels into the legs, or pneumonia can cause abdominal pain, and very minor symptoms can actually be caused by major disease. The physical exam, unfortunately, is very unreliable, and so you're going to rely on a number of things, particularly the history, to give you a clue as to whether or not the patient is very ill or if this is mild disease. Over the next few slides, we'll briefly review anatomy. This is the abdomen opened up, obviously a male patient, and we've got everything removed to the posterior abdomen. So you see on the patient's right a kidney at approximately halfway up the image. Directly to the left of that is the vena cava and the aorta. You've got the posterior muscles. Down low you've got the bladder and then the external genitalia. This CAT scan image is taken at the upper abdomen. Those large black areas are the lungs, and that grayish area in the patient's right anterior section is the liver. The bright white bone structures in the back are bones, the vertebrae and the ribs. And just in front of the vertebrae, that large grayish circle, is the aorta. Just to the right of that, patient's right, is the vena cava returning. So you can see that a good part of the abdomen, the liver, is already present, while there's still quite a bit of lung as well in the patient's posterior back area. And there can be quite a bit of overlap between those two from the nipple line to about the level of the umbilicus or belly button. This next cut is taken a bit lower. Again, that large gray organ to the patient's right is the liver, and the darker pear-shaped thing lying in the front part of that is the patient's gallbladder. The kind of poofy cloud-looking bright white structure in the patient's left anterior abdomen is bowel, and it's bright white because it's got contrast material in. Just behind that is some non-opacified bowel that does not have contrast material in. And on the left, just before you see the bases of the lungs, those black areas, you see that long gray structure. That's the back part of the patient's spleen. So again, we're still seeing quite a bit of lung as well as intra-abdominal organs. This cut is from lower down. At the very patient rightmost area, that up and down gray structure, that's the tip of the liver. Directly to the patient's left of that is the kidney. That's the right kidney. Then you see the vertebrae, the bone, and on the other side is the left kidney. And all those loops in front of that are bowel, both the opacified ones and the ones that have the white in them, plus the gray that looks like it's full of air. That's stool and food being digested. And then that web-like structure that you can particularly see in the patient's left anterior abdomen is called the omentum, and that's that basically attaches the bowel to the abdominal wall, and then it's a big area of fat, or big fat organ that crawls over the bowel and protects it, helps with fight infections and to protect the bowel from injury. This cut is from much lower down. Those white two bright white structures you're seeing are part of the pelvis. So you're down at the level of the pelvis, almost to the level of the hips. The large, round, gray structure that's most anterior is the bladder. Just behind that is the uterus. And then just behind that, the gray structure with the little black dots, which are air in it, is the rectum. So that's where stool comes out, and then that bright white bone behind it is the bottom of the sacrum and the beginning of the coccyx, the lower bones of the spine. This is a coronal view of the abdomen. This is fairly anterior. Starting top to bottom, you can see those black areas, those are lungs, and that white right between the lungs is the heart. Just under it, on the patient's right, that large organ is the liver, and that round, darker gray circle in the lower right corner of that is the gallbladder. You can see the stomach underlying the liver, and all those white loops of bowel scattered throughout the abdomen. You can see the relationship of all those to each other. And on the bottom, you see that gray area, that's the start of the bladder. Now, if you look up at the chest, right along the edge of the liver, and on the other side, on the bowel, you can see there, those white ovals are cross sections of the ribs. So the liver is actually tucked well up under the rib cage there, and the diaphragm is well under the rib cage. That's almost up to the nipple line. This is another coronal shot, a little bit more posterior in the patient. You can see a lot of the same structures. You can see a little bit of fuzziness right underneath the liver towards the midline. That's the pancreas. It's a structure that's involved in digestion and blood sugar control and can get inflamed from alcohol or gallstones or very high triglycerides. You can see the bladder well and the bones of the pelvis. And a new structure that you're seeing, that upside down looking V, is where the aorta splits into the iliac arteries and goes down into the pelvis. This is another coronal image taken much more posterior. You see the lungs, you see the liver in the patient's right upper quadrant, you see the back of the stomach and the spleen in the left upper quadrant. Those two structures directly underneath both of those are kidneys, and they're in the retroperitoneum. They're not actually inside the abdominal cavity, they're actually outside of it, tucked right into the muscles of the back. And then you can see the backmost structures of the pelvis, those bones there, where those white midline structures, those are parts of the spine, vertebrae in the spine. And down low in the pelvis, you can see both the uterus and part of the rectum where those structures overlap each other in this cut. So here's the part that really matters. Again, the abdomen is the cavity of mystery, and it's very difficult to figure out what's going on. So much more important than exactly what the disease process is, you need to know, are they sick or are they not sick? If any of these things are present, this patient is sick and they need to be evacuated. So severe abdominal pain, vomiting that will not stop, no bowel movements and not passing gas, or throwing up stool, feces, an abnormal blood pressure, particularly abnormally high or abnormally low, both of those are bad signs. If their heart rate's fast, that may be a bad sign, although pain can also make the heart rate go up. Peritonitis, which is inflammation of the lining of the abdominal cavity, and you find that by just tapping on the abdomen. And if tapping on the abdomen or pushing in on the abdomen and then letting it out hurts, or even tapping on their heels makes their stomach hurt, those are bad signs. That means that something is irritating the lining, and usually that means there's an infection or a leak somewhere. A pregnant patient with abdominal pain, that's a problem. If they have moderate or large amounts of bright red blood in either their stool or their vomit, that's a problem. Tiny little bit of blood in the stool or throwing up ones with specks or flecks of bright red blood are usually not a big deal as long as all the vital signs are normal. But they're definitely something to discuss with medical control. But if it's moderate to large amounts, that's bad. They're sick. Anyone with abdominal pain and a fever, that's very concerning. Severe flank pain can be a kidney stone, and you need to sort that out. It can also be the abdominal aorta ripping and starting to leak. Anyone over 60 who's having abdominal pain, that's at least concerning enough to talk to medical control. immediately and possibly for evacuation. And if you put your hand on their abdomen and you can feel something pulsing, and it's a mass and it's the center, and they're having abdominal pain in that area, that's a very bad sign. It means they have an aneurysm of their aorta, and it's probably pretty close to bursting, and if they're already having pain, then it's probably already leaking. So beyond that, there's probably not a whole lot that matters. You're not really going to be able to differentiate well between the various diseases. So you'll play the odds, and we'll talk about what the various diseases are and what kind of symptoms they can cause, knowing that, in fact, you may be wrong, and so following these people over time is probably the most important thing you can do. So starting from the top, esophagitis, or inflammation of the esophagus, the food pipe that connects your mouth to your stomach, or GERD, gastroesophageal reflux disease, can cause abdominal pain. And this is basically chemical inflammation of the esophagus, or potentially an infection in the stomach causing a gastritis or an ulcer. People with a viral gastroenteritis, a viral infection of the stomach and the bowel, can get a lot of reflux and burn as well. So you get heartburn symptoms, upper abdominal, and a chest burning discomfort. The problem is that a heart attack can present like this, a pulmonary embolus can present like this, and someone who's got bleeding from the stomach, the upper GI tract, the esophagus, can also present like this. So if somebody has these symptoms, talk to medical control about making a decision about what's going on with them. So going down a little bit lower, gastritis and peptic ulcer disease, or PUD, can also cause upper abdominal pain. And that's inflammation of the stomach wall, and in peptic ulcer disease, an ulcer in the stomach or the duodenum, first part of the bowel. It can be from an infection, or it can be chemical from too much acid. It gives you pain in the epigastrium, which is the area just above the stomach, or thinking about it, it's the space between the lower part of your breastbone, what's called the xiphoid process, and your belly button. That's your epigastric area. Again, things that aren't gastritis and peptic ulcer disease that can present like this include a heart attack, an upper GI bleed, problem with the gallbladder, pneumonia, or appendicitis. Now you'll be able to differentiate some things, like appendicitis, for example, based on where the pain's going to. Probably will also be able to distinguish pneumonia, because the patient will typically have a cough as well and some shortness of breath. But it can be very difficult to sort these things out. So again, someone with epigastric pain, talk to medical control. Now, nausea and vomiting are going to be very common complaints, and they may or may not be accompanied by abdominal pain. If the patient has abdominal pain, nausea, and vomiting, you need to think about more significant disease. Just nausea and vomiting may be benign, but it may not. It's a combination of chemical triggers, things that irritate the stomach and the mouth, your brain and the way it's interpreting signals it's getting, and some physical triggers like movement. And the big concerns for you is an infection versus motion sickness, but really anything can cause nausea and vomiting. People having heart attacks will have nausea and vomiting. Hopefully they'll have other symptoms as well, but nausea and vomiting can be presenting symptoms. So talk to medical control. If it looks like it's something severe, you're going to want to evacuate them. If it's just motion sickness, an anti-vertigo medication or an anti-nausea medication, or a combination of both, may be very helpful. And if it's gastroenteritis, which is a viral inflammation of the stomach and bowel, usually accompanied by diarrhea, an anti-vertigo or anti-nausea medication, as well as fluids, either by mouth. Hepatitis is another common cause of GI problems. What hepatitis is, it's acute inflammation of the liver, and it can come from any number of causes: infection, chemical or toxic exposures, or obstruction from gallstones. So the most common are hepatitis A, or toxic hepatitis from alcohol. Hepatitis A is from the hepatitis A virus. The toxic issues, obviously, are self-explanatory. The typical presentation would be abdominal pain in the right upper quadrant, nausea and vomiting, and then the whites of the eyes turn yellow, and that happens early, and then the skin turns yellow, and that's called scleral icterus and jaundice. So what do you do for these patients? Well, it depends on how sick they are. You contact medical control, and if they're very sick, they may need to be evacuated.
Pancreatitis is another common cause of abdominal pain. The pancreas is a large organ. It's in the upper abdomen. It crosses the midline, and it's responsible for digestion and managing blood sugars with insulin and glucagon. And it can get inflamed for pretty much the same reasons as the liver, so infection or chemicals, or from obstruction. And so alcohol and gallstones are the most common cause of pancreatitis. Very elevated, very elevated triglyceride levels in the blood, fats in the blood, can also cause pancreatitis. And the presentation tends to be of severe upper abdominal pain that may go straight through to the back, associated with nausea and vomiting. And your treatment will typically be IV fluids and pain control and an anti-nausea medication. And in mild cases where the patient feels better, you may be able to keep them aboard with just a clear liquid diet. But if they're sicker than that and they're in severe pain or can't tolerate any fluids, they'll need to be evacuated. Appendicitis is another common cause of abdominal pain, particularly in younger patients. The appendix is a small sac that attaches to your small bowel and large bowel junction. So it really hangs off the large bowel right where the small bowel joins it. And that's typically in your right lower quadrant, although people can have their appendix in other places in the abdomen. And what happens is that the appendix gets blocked and gets inflamed and basically becomes an abscess. If it gets enough inflammation, it ruptures. So the classic presentation is someone who starts with general abdominal pain, particularly periumbilical pain, right around the belly button, with nausea, vomiting, fever, and loss of appetite, which is what anorexia means. And then that pain localizes to the right lower quadrant. So it goes from being generalized or around the belly button down into the right lower quadrant, and that's called peritonitis. There's inflammation of the peritoneum, the lining of the abdominal cavity, and when that, if the appendix leaks or ruptures, the peritonitis can be severe. Now that's the classic presentation. In reality, anyone with abdominal pain that's getting worse and localizing, particularly the right lower quadrant, you have to be concerned about appendicitis. So how you manage appendicitis is going to depend on how suspicious you are. So you'll talk to medical control. If it's an unclear case, so generalized abdominal pain, maybe a little loss of appetite, but not necessarily, no fever, they may say, okay, let's observe them for a while and see how they do. But if there's a high suspicion, so the pain localizes to the right lower quadrant, they have peritoneal signs, and you remember those are the findings we get with percussing the abdomen or tapping on the heels or making them jump up and down, then your suspicion's high. You need to evacuate the patient, and in the meantime, you give them IV fluids, you give them medication for pain control, morphine typically. You keep them NPO, which means they can't eat or drink anything because they're going to need to go to the operating room. You give them IV antibiotics, and the one that you have is ceftriaxone, as long as they're not allergic. Now, diverticulitis is another problem that's in some ways kind of like appendicitis in terms of what happens. We used to think of this as a disease of people over 40 and really over 50, but now, thanks to the very unhealthy American diet, which causes a lot of constipation, we actually see this in patients as young as their late teens and early 20s. And basically what happens is the wall of the large bowel pouches out between the muscles that run along the large bowel. And that's called diverticulosis. And those little outpouchings, which look like little pockets, can become obstructed and infected. And when they do, that's diverticulitis. And if they get infected enough and they rupture, they form a large abscess. So the presentation is typically left upper quadrant or left lower quadrant abdominal pain, although you can get this anywhere along the colon, so right upper and right lower quadrant pain is also a possibility. The pain tends to be achy and dull. Oftentimes the patient will have blood in their stool, and they may have diarrhea, and they may have a fever. And if the patient has a known history of diverticulosis or previous diverticulitis, that's pretty helpful as well. Now, if you think someone has diverticulitis, talk to medical control, and your big clue on this is going to be they have a previous history of diverticulitis or diverticulosis, and they say this feels like their previous diverticulitis. So you talk to medical control. If they agree with you and the patient's not sick, they have no peritoneal signs, their vital signs are normal, they don't have a fever, you may be able to keep them aboard with pain medications. and oral antibiotics. And keep in mind that pain medications, particularly narcotic pain medications, tend to be constipating, so you'll probably need to put them on a stool softener as well to help control that, because the constipation can actually make things worse. If they're sick, they've got peritoneal signs, they've got nausea and vomiting, can't keep anything down, they have fevers, they have abnormal vital signs, they need IV fluids, IV pain medications, IV antibiotics, and evacuation. And in this case, ceftriaxone is not the best choice of antibiotic in the world, so medical control may add some oral antibiotics as well. Talking now about genitourinary problems. First one we want to talk about are kidney stones. Those are very common, and basically your kidney, where it collects all the urine, has a big open space called the pelvis, and it can make small rocks. And those small rocks just sit in there and are fine, and then when they start to slide down the tube that connects the kidney to the bladder, the ureter, you've got this little sharp, jagged rock about the size of a grain of sand sliding down through a tiny tube. And that can cause severe, sharp stabbing pain on the side of the stone. The patient may have nausea and vomiting, the pain is so severe, and they may see blood in their urine. The problem is this can look like a ruptured AAA as well. So if you've got a patient who you're worried about an abdominal aortic aneurysm, they're above 50, they smoke, they have severe abdominal pain, severe flank pain, you have to consider the AAA or ruptured AAA as a possibility. So talk to medical control. You're going to want to dip their urine with a urine dipstick to see if there's blood. If there is, that helps a lot. It's not 100% saying it's a kidney stone, but it is pretty helpful. And then pain meds, IV fluids, anti-nausea, anti-vomiting medications. And if you can't control their symptoms, you may end up having to evacuate them. Urinary tract infections are also common genitourinary problems. They're much more common in females, and the reason why is that the small tube that connects the outside world to the bladder, the urethra, is much shorter in females. So the typical symptoms can be divided into whether or not someone has a lower urinary tract infection, the bladder or the urethra, or an upper infection, which includes the ureter and the kidney, and then also the urethra and bladder, since they're downstream and are infected as well by definition. So in a lower tract infection, you've got pain just above the bottom of the pelvis there, where you can feel the bony pelvis. You go right above that. Pain in there, often tenderness. It burns when you pee. You may feel like you have to pee a lot, and when you do, only small amounts come out, and low back pain. Upper tract infections are as above, but also pain higher. The kidneys are protected by the rib cage in the back, so the little angle between the lowermost ribs and the spine is called the costovertebral angle, the angle between the ribs and the vertebrae. And that's where the kidneys are. So if you tap there, that's often very painful for these patients. They'll also have nausea and vomiting, fevers and chills. And potentially, if the infection's bad, they can be in septic shock. So their body is starting to have multi-system organ failure because of the infection. So abnormal vital signs, shock symptoms, decreased blood flow to the extremities, confusion, all sorts of other things. So what do you do for a UTI, a urinary tract infection? Well, you start by dipping the urine. And your urine dipstick typically has two indicators on, one called nitrates and the other called leukocyte esterase. And those become positive with infections. So you talk to medical control, and if it's a simple lower infection, no fever, no systemic symptoms, oral antibiotics usually will work. If it's an upper tract infection, oral and maybe IV antibiotics. You may need anti-nausea medications. If they can't keep down fluids, they may need IV fluids. If they're very uncomfortable, they may need pain control, IV narcotics or oral narcotics. And if they're septic or very sick, they will need to be evacuated. Another problem for males is called testicular torsion. And basically the testicles hang from a cord that goes up into the body. They hang in the scrotum, and then they're usually attached to the bottom of the scrotum as well. But otherwise, they're kind of free hanging with these two attachments, one on the bottom and one on the top. And the testicle can potentially twist on itself, twist around that upper tube, and cut off the blood supply, because the blood comes through that tube. And so the testicle dies over a 4 to 6 hour period. And the presentation is sudden severe testicular pain, either after trauma, or sometimes it can happen without trauma, In younger individuals, being very active, exercising can do this. And the pain may go away and come back as the testicle twists and untwists on its own. That's called torsing and detorsing. So if someone's got this kind of pain, you talk to medical control, you need to evacuate them. And if the pain is continuing, it's an emergency because otherwise they'll lose the testicle. And if it's going to be delayed and you're not right at the dock, you may need to talk about what are called manual detorsion techniques, where basically you take the testicle and you untwist it, and medical control can walk you through that. So now we'll talk about female obstetric and gynecologic problems, and what we're talking about is early pregnancy obstetric problems. So any female of reproductive age with genital complaints or abdominal pain, unless they've had a hysterectomy, they have no uterus, or an oophorectomy, they've had their ovaries removed, you have to assume they're pregnant. Someone who tells you that they've had their tubes tied, that doesn't matter. They can still get pregnant. So you need to do a urine pregnancy test, and that divides your issues into OB problems or gynecologic problems. And there's a big difference in how you manage these. We talk about baby catching, delivering babies elsewhere, and we talk about sexually transmitted diseases elsewhere. So we're just going to focus on early pregnancy and gynecologic emergencies. So let's first talk about obstetric problems. You have a positive urine pregnancy test. If this is a newly diagnosed pregnancy, the pregnancy can be in the uterus or outside of the uterus, intra or extrauterine. If it's outside of the uterus, it's called an ectopic pregnancy. That's usually in the fallopian tubes, the tubes that connect the ovaries to the uterus, but really it can be anywhere in the abdomen outside of the uterus, and you can't tell based on your exam or history. The problem with an ectopic pregnancy is that as it grows, if it ruptures, the woman can bleed to death. In a miscarriage, if the patient's having vaginal bleeding and they're pregnant, they're having abdominal pain, they could lose the pregnancy. And it matters whether or not it's less than 20 weeks or more than 20 weeks. There's really not a lot to be done before 20 weeks. If you're going to lose the pregnancy, you'll lose the pregnancy. There's no medical techniques or anything to help save the pregnancy. Beyond 20 weeks, there is treatment that's done, and so it's worth offering the opportunity for evacuation for that patient. Now, if that patient didn't know they were pregnant before, or they knew they were pregnant but they haven't had an ultrasound proving that the baby is in the uterus, it may be an ectopic pregnancy. It may be outside of the uterus, and you can't tell from the history. So if the patient doesn't have a known intrauterine pregnancy by ultrasound, then you have to assume it's an ectopic pregnancy. So what do you do? Well, if the patient's having abdominal pain and you have a newly diagnosed pregnancy, talk to medical control. They need to be evacuated to be worked up for an ectopic pregnancy. Ideally, they get an ultrasound within 12 hours of you discovering that they're pregnant. However, if they're not sick, you really have 24, 48, maybe even 72 hours to address this. If they're sick at all, abnormal vital signs, peritoneal signs in the abdomen, severe pain, they need to be evacuated immediately. If you have a patient with vaginal bleeding in a newly diagnosed pregnancy, talk to medical control. Again, if they're not sick, you can wait up to 3 days to get the ultrasound to evacuate them, but if they're sick at all, they need to be immediately evacuated. Again, if this is a known pregnancy and there's an ultrasound showing that it's in the uterus, then talk to medical control and you make a decision based on how far along the pregnancy is. So if the patient isn't pregnant, then really there's only two issues that they'll typically present with that are gynecologic related, other than the STDs that we discussed elsewhere, the sexually transmitted diseases. And that's vaginal bleeding. And if a patient presents with vaginal bleeding, you're not going to do a pelvic exam. Get a good history of how much bleeding there is. How many pads are you soaking? Are you completely soaking a pad in an hour? Are you soaking a pad in 12 hours? And if they have blood soaking through their pants, that's a lot of bleeding. So you want to talk to medical control, and your decision about evacuating them will depend on the amount of bleeding. Also, in the circumstances, if there's no way to evacuate them, you may need to track down oral contraceptives, because sometimes high-dose oral contraceptives can be used to control dysfunctional uterine bleeding. Now, if the patient has abdominal pain, the thing that you need to worry about is something called ovarian torsion, lower abdominal pain. Just like with testicular torsion, the ovary can also twist around its own blood supply and it will die over time, a matter of hours. It's very, very hard to diagnose. There's this classic picture of it, which happens less than 5 to 10% of the time, in which the pain has severe pain on one side. It comes and goes as that tissue torses and detorses on itself and gets blood supply and then no blood supply. That's the classic picture. It very rarely happens. In reality, it's usually a dull, aching, one-sided lower abdominal pain that's persistent. The bad news is the vast majority of these are missed. If they're not detorsed within 12 to 24 hours, the ovary dies. The good news is that it doesn't actually affect fertility. As long as the woman has a second ovary, hasn't had that one removed or hasn't had torsion on that side, as long as they've got a second ovary, that one actually takes over all the work, and so the fertility remains the same. Please complete the knowledge review and make sure that you understood all the concepts from this presentation.